Okay, and good afternoon, everybody. Welcome to the Overdose Prevention and Pain Management Council meeting. Today is November 17th, 2023. I'm Dominic Zerlo, and I'm the chair for this council. And our first order of business will be, of course, to do our introductions and to ensure that we have our council membership here. So I will start going through the council membership or members. If you are here, please indicate that you are here by saying yes, or if you're having an issue with regard to microphone, you can also put it in the chat as well. So is Monica Rincon-Smith on today? Okay. Mackenzie Chase Enrique. Okay. Ernie Dole. Okay. Elizabeth Boyce.
I'm here.
Thank you, Elizabeth.
Thank you, Elizabeth.
Elizabeth Dyer. Phil Feudy.
I am here.
Good afternoon, Phil. Leslie Ann Hayes.
I'm here.
Good afternoon, Leslie. I do know Melissa Hines did let me know she would not be able to attend today. And Steve Jankuski. Joanna Katzman will be on later. She is running a little bit late. She did inform me of that. Elizabeth Lacouture.
Hi, Dominic.
Hello, Liz. How are you today?
I'm well.
Glad to hear. Andrea Maloney.
I'm here.
Welcome, Andrea. Thank you. Sharon McCracken. Okay. Scott McFall.
Present.
Thank you, Scott. Welcome. Darcy Pope Wyatt. Charles Schumacher did let me know that he has actually retired from the board of dentistry. So we are awaiting. I may as well make that announcement right now. We are waiting for the governor's office to appoint somebody new, or for the board, I should say, to appoint someone new to the governor's office for the council. But we definitely would like. Oh, my apologies. I realized I somehow went muted. Not sure how much people heard. What I was just saying is that Chuck Schumacher has retired from the Board of Dentistry, and so we are waiting for a new appointment for that position. But we definitely thank him for his service, and he's been on this council for many, many years. So thank you to Chuck for that. Randall Starling, are you here today?
Yes, here. Hi, Dominic.
Great. Hello, Randall. Thank you. Brandon Taylor. And Brandon Warwick, have you made it? Brandon also let me know he was running a few minutes late. And then Jennifer Burke also let me know she would not be able to attend today. And then myself, Dominic Zerlo, I am here and present. Is there anybody who was a council member who may have joined since I started reading off the names and may have missed theirs? And of course, I will also check against our list after the meeting has completed. So at this point in time, I just do a review of our agenda for today. And so it should be sharing on the screen now. And basically, it's just our review of the minutes, the council membership status. We do have a presentation from Josh Swatek on an update of harm reduction and overdose prevention activities in the harm reduction program. The subcommittee updates and recommendations, and then some other business. Now, we do also have an announcement from Brandon and from Joanna. But we will wait for Joanna to come on in. So we'll give it a couple of minutes more for that. In the meantime, if I could have the council members review through the minutes from our last meeting. They have been posted up on the website for several weeks, and they were also sent with the invitation. I'm not going to scroll through all of them. I did have a request after the last meeting. Some people found it a little visually challenging with my doing the scrolling, so I'm not going to scroll through all of them. I would just ask if there are any issues or concerns with the minutes to let me know. And even if you miss them at this time and you see it afterwards, to send it to me in an email and we can get those updated for the next meeting. But in the meantime, I'll let the minutes sit here so everybody can see if there are any changes that need to be made. Okay, does anybody have any objection to the minutes? Yeah. Okay, well, thank you very much, everyone. I will go back up to our agenda now. So our next item, as I mentioned during the roll call, Chuck Schumacher has retired from the Board of Dentistry, and so we are awaiting for a new appointment through the board and then the governor's office for that position. Other than that, at this time, we do not have any other changes for the for our agenda. Oh, and I do see someone had their hand up. Was that, and I just missed it? My apologies. Going back and forth between the screens, it may take me a moment to see it. Did somebody have a question? No? Okay. Sometimes those phantom hands just raise up during the meeting, so we'll go ahead and we'll move forward. And so our next item is the presentation from Josh Swatek on harm reduction and overdose prevention. Josh, I do see you are here, so I will turn the floor over to you.
Yes, I am here. Hey, everyone. Great to see you today. Thanks for having me. I just want to give a little bit of a quick update on what we've been up to in harm reduction over the past, it's been a little bit since I've talked to y'all. So give me just a second here, find the right screen. Sorry if you slides to keep me on track. So what have we been up to this past couple of years? So I will start with my obligatory data slide that shows kind of what the harm reduction program looks like. So, you know, in 2019, we really saw that shift to fentanyl, and by 2021, 2022, we saw that black tar heroin was pretty much non-existent in our community, which led to us passing HB 52, which was recommended by this council. So we got it through. It was a DOH bill. It was a governor-sponsored bill, which expanded what we were able to offer in the harm reduction program. So we were able to offer, you know, smoking supplies, inhalation supplies. It gave us that rule-making authority that we didn't have before. So we got that. We made those rules in about a year ago today, I think, actually, is around the time that we had the rule hearing, and we got those published in December. So what we saw from that is, you know, we saw an increase in participation, a number of folks participating in the program by 1,000 people. That was probably due to us having the supplies that they needed. So that was actually a big success for us. It started that first 6 months that we had supplies that we could offer. Folks were coming in more because we were able to offer the supplies that people are actually using to consume substances. So that led us to being able to have more of those interactions with folks, providing health messaging, providing all the other services that go along with harm reduction. Because remember, harm reduction is not just about handing out things. It's not about handing out syringes or foils. That's the smallest, tiniest piece of what harm reduction is. To give you an idea about what that looks like now. So we used to hand out millions of syringes a year. I think our peak was a few years ago at 16 million. Last year we handed out about 3 million, right? So it's really decreased. But if you look here at that last bullet, so far this fiscal year, right? The fiscal year that started in July, 80% of the interactions that we've had with people have involved providing smoking materials. So that gives you an idea about how the substances, the supply has changed and how folks have changed how they're consuming substances. There's a lot to go around with that. There's a lot of things that go along with switching from injection to smoking and inhalation. We won't get too much into that today, but I think it's good that we're able to address those needs of our community here in New Mexico and with the harm reduction program. So we made those rules, we made all these changes. And I want to talk about naloxone distribution. Everyone always talks about naloxone distribution. So in state fiscal year 23, the last year that we have full data for, right, fiscal year, we gave out exactly 25,000 doses of naloxone, which in my public health career, I've never seen exactly 25,000 of anything. So I like to point out that number just for fun. We had 3,075 individuals reported okay after someone used naloxone. So that's 3,075 times that someone used naloxone on someone else, came back to us and said, hey, I need more because I used it on someone. And then we asked, well, what happened? And they said they're okay. So over 3,000 times, that's a potentially time that someone's life had been saved. Since May of 2022, we provide over 150,000 fentanyl test strips. Those are ongoing. Those are integrated into our program. We always get asked, exactly how many do you hand out? I'm like, I don't know exactly because we don't count how many because we just integrated it into our supplies. People grab them as they're needed. We put them in the overdose response kits. So that's definitely helping out the program, letting people know if there is fentanyl in their substances, especially when they're not suspecting it. It makes them more aware. And we're thinking that this adulterant checking is probably leading to those better health outcomes overall. As part of our naloxone campaign, if you are active on social media, you might have seen this. We did a pretty decent buy. I'd like to thank Kelly Watson from our team and Vital Strategies team and our marketing team here at DOH in creating this campaign. It's the Naloxone Saves Lives campaign. We're actually going to print out a bunch of posters and cards, some fancy stuff here, but this is also a social media campaign that's ongoing. And it directs you to nmharmreduction.org. So nmharmreduction.org is a cool website. It's our website. It tells you basics of harm reduction. We're really building it out to be replace our DOH website because it looks prettier basically. But the cool thing about this website is that you can order naloxone from it and get it directly delivered to your house. So you can get a box of naloxone delivered directly to your house. Just online, no questions asked. We ask a few questions. You don't have to answer them other than address. We need to know where you ship it. But this has actually been really successful. So this launched on August 30th, and we provided over, let's see, I think we provided around 1,900 doses of naloxone since August 30th through this program. And had about 480 different folks order, I think is what it is off the top of my head. We're still getting the data from it. So it's popular. We're getting, orders every single day. So if you know someone, especially in a rural community that doesn't have access to naloxone, this is a great resource. Now, if you do have resources, if you have naloxone, you just want to test this site out, I ask you not to because it works. We had a bunch of people like, oh, I want to test the website out. And we were having like 40 orders a day. But it kind of ran out of our naloxone. So if you just want to test it out, don't worry, it works, it's fine. We've already tested it out. But if you know someone that needs this service, please let them know about it. Another exciting thing we've got, I saw Phil on today, so he might chat about that a little bit more in a bit, but we've got adulterant checking. We've got FTIR machines in state and operational at 2 harm reduction locations. So there's a lot that goes into adulterant checking at a harm reduction location. It's not as simple as stick the substance on the machine and push the button. It tells you exactly what's in there. So it's actually a really more complicated process But it's really good that we have harm reductionists doing that, because the people who understand the supply of substances in New Mexico more than anyone are the people who are using substances and the people who are working with people who use substances. This is going to give us a really good opportunity. It's going to be an early warning system to make sure that we have something like, when fentanyl came along, we kind of got caught flat-footed a little bit because we couldn't make those changes. We were stuck with some of the regulations. We've changed those. This will give us that early warning so we can get accurate health messaging it out. And it will also help us counter the inaccurate health messaging. So I know earlier this year, there was a lot of concern about xylazine. Xylazine was everywhere. It was in the news. They were saying it was all over New Mexico, and it wasn't, right? So there was a lot of panic, and that panic drew attention away from a lot of the very real issues that were happening, the polysubstance use, the overdoses that were happening, what was actually in the supply right now. So it took attention away because there was inaccurate health messaging by some federal agencies. And we can counter that now because we'll have this tool along with all the other tools that we have, like OMI, Crime Lab, that can tell us really what's in our supply of substances. We can tell this, and this is also a public service, so we can tell people what they're using too. So they can be aware of what they're using and use harm reduction techniques to change their use behaviors to potentially avoid an overdose or other negative health consequences associated with substance use, or something that they weren't expecting. So some more things. So I went over kind of like a brief overview of what we've done over this past year so far, past couple of years since I've talked to you. So here's what's happening more this year. So we're increasing our person-centered navigation into MOUD services. We're using the opioid settlement funds to do this. And when I'm talking about person-centered, we're not saying that, the whole goal is to make someone be more likely to succeed in a treatment service. So it's not just saying, okay, you got into treatment, that's success, and we're going to pay per individual harm reduction navigate into treatment. It's navigation of things like food, housing, childcare, ID services, insurance, anything that would make someone be more stable and more likely to succeed in treatment. And it also does include navigating people into treatment, making appointments for folks, driving people. I know some of the agencies are also doing contingency management with some of their MOUD programs. So we've talked about that with methamphetamine a lot, but there's also evidence that it shows with MOUD. So it's kind of an add-on that might not be paid for in another mechanism. So we're able to use these funds to support those efforts. We're also refocusing on infectious disease here in the harm reduction program. So the history of harm reduction in New Mexico, we were really founded as an infectious disease program to prevent bloodborne pathogens. And we still are that as well, but we also know that we have other infectious diseases right now. So syphilis, congenital syphilis is a big issue, not just here, but across the nation. And a lot of the folks who are most at risk for passing syphilis on to a baby are folks who are using substances who aren't engaged in the healthcare system, but they could be engaged with harm reduction programs because they trust us. So as of this year, all of our harm reduction providers are required in their contract to provide incentivized syphilis testing so that we can link people into care, get that treated, and hopefully reduce the community basically bacterial load of syphilis, so we can really improve those outcomes for the folks who aren't engaging in medical systems. We're also engaging in really focusing on rebuilding relationships with our community members that are coming in to see us. I know during the pandemic, a lot of folks got, in habits of coming in and leaving and really quick interactions. And we really want to be more engaged as a program. Harm reduction is successful because it builds relationships, not because we hand out supplies. If it was all about supplies, I would just buy a bunch of vending machines and I'd have the easiest job in the world. I would run a vending machine empire, right? But that's not why harm reduction is successful. People aren't more likely to get into MOUD in harm reduction because they have supplies. They're more likely because they've built a relationship with someone that they trust, that they can navigate into healthcare systems. So that's really what we're going to be focusing on over the coming years, is improving our services and improving that relationship building within our communities. We've also expanded naloxone distribution channels. We've talked about that a lot, how we've really expanded who we're handing out to. We're reaching that saturation point. We're also working with probation and parole in New Mexico corrections. We've taken over naloxone distribution and training for New Mexico corrections, and soon we'll be offering them in probation and parole offices in a way that is easy for folks to access. So basically what's going to be is we're going to have naloxone that's going to be sitting out for people to grab, because we know there's a barrier to asking your probation officer for Narcan. So if it's just out there for someone to grab, sort of like, just easy to get, that's going to reduce some of those barriers and make naloxone more accessible for folks who might need it more. I also want to mention, this is probably its own entire separate presentation, but we're building capacity for mobile services for folks experiencing homelessness. So the governor's office tasked the harm reduction program with providing, creating a program, a demonstration project to build capacity in rural communities across the state to bring services to individuals experiencing homelessness to where they are. So using the harm reduction model, meeting people where they're at, both literally and figuratively. So that's ongoing right now. It's part of the governor's larger mobile homeless service initiative. It's about building that capacity, training folks who might not be used to working with folks directly in the street, in all across the state. And the reason that it's rural primarily focused is because all the federal dollars really get focused in places like Albuquerque, Las Cruces, Santa Fe, and sometimes our rural communities miss out on those federal dollars. And it's actually harder and more expensive to reach folks in those rural communities because you have to do a lot more work, a lot more hours. So the state's really investing in making sure that we have that capacity. And the harm reduction program has been tasked with that. So that's what's been happening this past year. We've been a little bit busy. We've had a little bit of expansion of our mission over the past year. So I just wanted to update y'all on that. And if anyone has any questions, I will answer them.
And Josh, Leslie has one.
Go ahead, Leslie.
Hey, Leslie Hayes. Question about the Narcan. I realized when I was recently going to give someone Narcan that the harm reduction supplies don't include face masks at this point. Is there any chance we could get those?
Yeah, sure. That's easy.
So it's already available through DOH, because they had said that they didn't have them for us.
Who are you going through for?
I don't remember.
Okay, yeah, we haven't bought them in a while, but we can buy them. I mean, that's easy enough.
Okay.
Yeah.
Thank you.
That's simple. Sure, why not?
And I also have been purchasing them all along for when I was at the Mountain Center. And I can direct you, Leslie, or and share with Josh information about where I was getting the best deals from on those.
Awesome. Thank you. Appreciate it.
And are there other questions
those
for
a while
Josh?
back because of budgetary issues, but I have to say our budgetary issues as of this fiscal year have been solved. Right, it's probably the first year that I can say the harm reduction program is actually fully funded to carry out its duties. In previous years, we've actually we've ran out of money by August. Right, and the fiscal year starts in July, so that has changed now. Like I still have money in our accounts, so we can buy those now. Yeah, good point. Thank you, Leslie.
Great, Phil.
There we go. Sorry. I know some of this because I already talked to you about it, but I was wondering if you could expand a little bit on the sort of bringing the focus back to infectious disease and some of the other navigation stuff with the programs.
Sure. So our program, again, like I said, is not about It's not about handing out supplies. It's about building relationships and navigating folks who need it into the services they need it, because we're friendly, we're nice, right? People trust us because we need to build those relationships. So that's why we're paying folks a pretty good rate for MOUD services. We're paying a pretty good rate for syphilis services, so that these services can be incentivized, so that agencies have the flexibility to really take time with people, take the time and get to talk to people, get to know folks, and not just, in and out on your way, which, if that's what someone wants, that's great. But, let's talk, let's chat with people while they're waiting in line. If they're in the waiting room, let's have a conversation, right? So it's really about getting a lot more of that back into harm reduction, because I think some agencies, not all, but some providers got away from that during COVID for good reason. And then we're coming back to that now that it's not the crisis that we were facing in 2020. So that's what we're doing, and that's really where the funding goes too, right? That's where the funding is at. So the reason that we're able to fund MOUD and sort of help bring that, great time to build those relationships back, is because that's what was appropriated by the legislature, right? We got funding from the legislature for MOUD expansion and navigation. And that's, that's kind of where money seems to be going in the future, both on the state and federal levels, is my prediction. So that's my little soapbox about that.
Okay, do we have other questions? I know there's been a few in the chat that have been being answered, so thank you, Paul, for also answering those. Appreciate that.
And I'm going to take a moment of personal privilege to congratulate Dominic. So in case folks didn't know, Dominic was recently promoted today to the director of the Administrative Services Division of the largest department in the state. So he'll be acting director of ASD here at the DOH. So congratulations to my good friend Dominic. And yeah, so that's. I will now leave it. I'll give it back to you.
Well, thank you, Josh. I really appreciate it. And yeah, it was just to let people know, it was just announced this morning. And so will be effective starting November 27th for those who are actually within the Department of Health. I still will be doing a lot of this work. I'm not stepping away from it. It's basically falling in under other duties as assigned. And many of you know that very well. So yeah, but I will be continuing working with regard to overdose and overdose prevention especially. So thank you, Josh. I appreciate it. Hey, are there other questions for Josh? Yeah. And thank you everybody for the congratulations in the chat. I appreciate it. Okay, before we jump to our next agenda item, Joanna and Brandon did have an announcement, so I'd like to turn it over.
Brandon,
Hey,
if you want to start, I
sure.
just have a couple of minutes. Brandon, if you want to start, I'll follow.
Yeah, I've got a little bit of noise in the background of the room that's periodically. Anyway, I just wanted to say Joanna and I are teaming up. She's bringing the UNM pain clinic. I'm bringing the UNM addiction clinic together. And we're going to do a year-long pain/addiction echo here starting early 2024. Things to know is, number one, there's no cost to you. This is we're using some of the opioid settlement money, so Big Pharma is paying for this. We are offering free CME on the physician, nursing, pharmacy, other healthcare providers as well. We can add those on if you need those. We've run this by DEA. And our understanding and what we've had back is that this will count for your DEA license registration going forward for your pain and CME. This is going to focus on New Mexico specifically, and some of the challenges that we have in the state. So I think that the way the echoes are set up is we're going to do the first half for 25, 30 minutes of a didactic. And then we ask the public or none, or you all to bring your difficult cases. And with an expert consensus panel, we provide some guidance or to help and hopefully optimize the care for your patients. As we realize that both getting an addiction consult as well as a pain consult is really difficult in the state. And so that's kind of the overview, but of it. I'll let Joanna put a couple other points in.
Right. Well, thanks, Brandon. Yeah, we just wanted to take a minute or two and we can hopefully find a way to share some flyers with registration links to people that you work with. We're so excited. We're bringing back, our original, for those who knew it, our original Echo Pain and Opiate Management Clinic. That people like Leslie Hayes and others know. And Leslie, if you ever want to come and be a guest hub team member, and others that want to come and, be part of it. The boards are still, for those of you who do or do not know, the DEA requires 8 hours of CME for those who are not able to get it in other ways related to addiction training. In addition, New Mexico has not abandoned the CME required for pain and or kind of addiction. We are going to, like Brandon said, start out with a series of eight hours over the course of 3 months that will fulfill any of the either medical, nursing, dental boards, and the DEA. And our team is made up of Brandon, myself, Radhika Grande, who's a pain management provider. And we also have a nurse on the hub team, and we also have a pharmacist on the hub team. So it's very interprofessional. Anyway, I think, and it's a traditional echo. So the thing that makes it work is if you guys present real cases, real de-identified cases, that's what really makes it work. And yeah, we can answer any questions, and we can bring more the next time we meet, more information. And I'm wondering, Dominic, if there might be a way that we'll have more information, like a flyer and how people can register for this, because it's going to be it is like Brandon said, it is opiate settlement money, and we do want to get the word out to our partners all around the state to be able to use this to help their patients with addiction and the fentanyl crisis and chronic pain, which starts so much, which is the beginnings of so many patients who have addiction. So we really want to get the word out. And I'm wondering if you have an avenue that we might be able to socialize this to the members of not only the voting members of the Governor Council, but people who attend this meeting.
Yeah, that's a great question, Joanna. And it's actually, I'll offer this to anyone really who's on, is all you have to do is send it to the Google group for the Overdose Prevention Council. So
okay.
It's that link that I send out regularly. If you send it to the Google group, it is moderated just so that we keep spam out, because we have had a few spam issues in the past.
Okay.
But you may notice probably the person who uses it the most to get information out is Phil, and it's very easy. You just send it to the Google Group's email, and then we just approve it, and then it goes out to the entire group. So
Great.
We're more than happy to do that. And that's for this, but also for everybody else here. If you have other specific trainings, announcements, things like that going on, you are welcome to send it to the group. Again, we watch for spam, so you don't have to worry about suddenly getting spammed with 6 million emails. So
beautiful, beautiful. And then the New Mexico Opioid Hub is Julie Griffin Salvador. Is she the one who is overseeing that website?
Yes and no. Rachel Abeta would be the best contact person for that. And I'm happy to talk about this one too, because this is another thing that I do. So Tuesdays at noon, we have a
I'm gonna,
substance
you
use.
guys, I'm gonna have to sign off. I'm gonna come back on momentarily, but I'm gonna let you talk about that, Brandon.
Yeah, so Tuesday afternoons, at lunch, over the lunch hour, we have a substance use disorder echo, and we've got about a 16 to 20 week rotating lecture series. I'll put Rachel's email and contact information in the chat if anybody's interested in signing up. And again, this one's free. This also applies to the DEA as well as Board of Pharmacy and those other requirements. Before Leslie asks, I don't know about the AAFP. We've never been asked that.
It would just be
Okay.
helpful if you could, just because AAFP has very specific requirements for CME, and if it can be AAFP certified, that would also help because it would be available then on the AAFP website, and so people could go to it from there.
I hear you, Leslie, and I might be calling on you to help me with that.
Okay, great. Are there other questions? All right. And if anybody does, again, if you missed, if you have other questions, you can send them in the chat, and or afterwards you can email those to me and I'll get them to the appropriate individuals. Okay, so our next item are the subcommittee updates, and first one will be Phil Feudy with Emerging Trends. Phil, the floor is yours.
Great, thank you. Well, that was a great segue actually to one of the things I wanted to bring to this group, based on some of the work that the council has done in the past responding to the CDC's request for input on updating regulations, and the other little subcommittee work that we've been doing, trying to bring adequate supplies of buprenorphine to our pharmacies across the state and things. I was going to, the DEA has recently put out to public notice. They call their notice of its 2024 aggregate production quotas, and the public comment is open until December 4th. My quick summary of it is that they are proposing for 2024 to diminish their quotas of Schedule II opioid medications. And this is based in part on the FDA's prediction that there will be a decrease of 7.9% of medications being prescribed, and then they have another couple of calculations they do measuring sales trends against what they calculate diversion has been, either from supply chain or from out in the world. And they also simultaneously are predicting an increase in demand for some of those medications for elective and other surgeries that were postponed because of the pandemic. The FDA is also predicting another 3.1% increase in the domestic need, U.S. need for stimulant medications. And as many of you know, there's also been shortage issues with medications for ADHD, and it's been causing a lot of chaos with particularly parents of children who depend on these medications. So it looks like they're planning to bump that a little bit. And then the exciting news in there, from my perspective, is that they are adding some Schedule I substances, including like Delta-9 and some other cannabis-related items, as well as psilocybin, and to me personally most exciting, ibogaine. And they're adding these in order to meet the need for increased research that is happening with those medications. So they're also proposing that rather than annually revise, and doing this on an annual basis with Schedule 2 substances, that they're going to drop it. They're going to implement a quarterly review so that they can, quote, be more nimble in averting medication shortages, allowing themselves room to move allocations back and forth between manufacturers, or being able to shift these allocations between totals for production quotas for domestic and those for export production. So if there's more of a need in the US, they can move some of that over. So my question for the council is, I think I would be a little bit concerned that they're planning to decrease the amount of opioid medications, availability of those. I know Leslie has reported in the process of us working on the Suboxone or the buprenorphine issue that, you know, there's patients that can't get their pain medications filled adequately. I myself personally have experienced that, and those issues don't seem to have been worked out. On the other hand, I do like some of the other things that they're proposing, and I was wondering if, as a body, we would be interested in composing some public comment on that. It is open until December 4th. Let's see.
So Phil, just from a timing perspective, it would be very difficult to do that as a council with such a short turnaround. Even when we did that with the recommendations, what was that, a year and a half ago, on the prescription guidelines or the treatment guidelines, that was something that really took well over a month to really put together. I just have concern about that. But what I would suggest is, if there are some individuals that are either on the council or just on this call, if they're interested, put your names into the chat, and Phil maybe call just a brief little meeting to have people review it outside the council. And then if individuals or organizations want to submit those as recommendations, they can do so. It just would take longer than the time we have remaining.
Right.
And I would hate for people to start work and do a lot of work and then not get recommendations submitted.
I agree. I see Leslie put her name there. What I'm going to do is, following this meeting, is put a link to the page that has the entire recommendations, and then folks can contact me directly through our through the council's site. Yeah, I just
Perfect.
found out about these a few days ago. So okay.
And I do think it's very important. It's just a timing issue more than anything else.
Yeah, I think that oftentimes in thinking about these things, you know, that it comes up over and over again that the needs of rural and frontier communities are not often factored in. I know what we've encountered in working on buprenorphine matters is that when the conversation got to the highest levels, they then turned around and their opinion was that it was uneducated pharmacists and things back at the point of care that were the cause of the issue. And we know yes, that happens. And also that is not largely what we've been experiencing in New Mexico. So I think, so I think just if anybody else is interested in working on that, I'm happy to do that. So, and then fortunately, we haven't really seen too much in emerging trends, but I will let everybody know when things like that do come up. If there's like some sudden change or some urgency with things, I will of course reach out through the list. to pull together. As Josh mentioned, the very exciting thing, which was a specific recommendation that came out of this, is we had our first training with utilizing the first two FTIR, Fourier transform infrared mass spectrometers. And we teams from the Mountain Center and from New Mexico Harm Reduction Collaborative, so Espanola and Albuquerque, along. Josh was in and out. Paul was there. Polly was there. Andrew Knox and Kelly Watson. Very exciting, and the way that the folks that conducted the training from organization Remedy Alliance. We actually got to fire up the machines and look at some stuff like right on the very first day. By day 3, we were set up over at NMHRC and testing real substances that had been submitted from participants. And we even had one participant towards the end of that day who wanted to see what was in his blue pill that he was about to use. And so we were able to look at that with that individual present, and opened up a whole new way of having a conversation with them. Very, very exciting. So those programs have that capability. We are working out some details. We're no longer calling it confirmatory testing because what my experience has been with programs that are doing this is that the more you learn, the less you realize you really know. And a lot of that is due to the fact that we're dealing with an unregulated supply. And by the time people are presenting us with things that they want to know what's in them, we have no idea how many hands it's passed through, whose pockets it's been in, and all the rest of that stuff. I won't go into the nuances of the testing and things, but yeah, truly fascinated. I'm very excited about that. Immediately following, as Josh said, last year, right about now, when we got all the stuff in place for House Bill 52, we began acquiring some samples, substances from folks through the Mountain Center and using a mail-in program with our partners at the University of North Carolina. NMHRC has also taken advantage of that service, and more recently, partners in Farmington and Silver City. And so we've gotten I've amassed over the past year a very nice sampling of things from all over the place. And just like to bring up that xylazine matter again. So far, nothing that's been collected through any of the harm reduction programs that people anticipated there potentially being xylazine in was found not to contain any, including that event that happened in Raton last April. Unfortunately, the news story that went out about that was never retracted, and I just saw a report from the advocacy folks at the American Medical Association listing xylazine as being found in New Mexico and referencing those news stories. So that is the way that we've always been managing things, and now all of a sudden we have an entirely different way of interacting with people on that. We're very excited. We're going to be getting 2 more machines. One of them is going to be located in Roswell and one in Las Cruces. What else? Yeah, and what's interesting too is that HIDA, law enforcement and the state crime lab have revised their numbers of what they were saying in terms of finding xylazine in drug seizures for this past year, down to some less than 1%. Maybe I can't remember what the exact number is, but it was a total of 8 times out of 3,500 drug fentanyl seizures. And as of September, the people at OMI have said that they have not identified xylazine as a in any of the suspected overdose deaths in New Mexico in the provisional 2022 and so far in 2023. So good stuff to keep in mind. The one thing we did find at NMHRC was a counterfeit Xanax that contained bromazolam, which is one of the illicitly manufactured benzodiazepines. And that has also been reflected through the crime lab data. It's one of those tricky things. It is detectable using a benzodiazepine test strip, but the amount of benzodiazepine that is active, even in a legitimate prescription pill, is so minute that we can't see them with the FTIR machines. Right, it's below the threshold detection with that, and so, but it did test positive with a test strip, and we got those results confirmed from UNC. The last exciting thing I'll say is, and this is due in part with Josh and Dominic and Brandon, it does look like Los Alamos is going to be our local partner in doing our complementary testing. So, and they have the ability to do a lot of the things that not all the labs do because they're Los Alamos. So we'll be able to, we'll do the basic GCMS gas spectrometry like UNC does for most things, but they're also going to be able to do quantification and any unknown substances and things that we get. So really exciting stuff, and hope we will have that worked out here shortly.
Great, thank you, Phil. Brandon, you had a question or a comment?
Yeah, I think a couple of things are just to add. I think one is, and just a caveat to what Philip is saying about OMI not detecting, is they haven't been routinely testing for xylazine as well. They did get a new grant here from the state that allows them to for lack of a better term, use a more expanded panel of tests. So it's very possible that based on how OMI has been doing the data, that we've missed some xylazine cases, and I think that's important. I've had a couple of meetings here in October and I with the HIDA people and and law enforcement, and the numbers that I was hearing were a little bit different than what Phil had in terms of xylazine being present. Was a lot higher than 1%, almost 1 in 17 cases. So I think Phil and we'll touch base offline and try to clarify that out. With that said, I'm in some of the cases that we've been testing in humans, I put in the chat that we're seeing quinidine or quinine as well as lidocaine. Both have been showing up or lidocaine has been in the drug supply for years, may have some implication for EMS as it's absorbed intranasally from snorting and cause some immediate cardiac dysrhythmias. And the same thing, quinidine also can cause cardiac dysrhythmias. In one case that we had, patient had a cardiac dysrhythmia. The quinidine levels were fairly low, and I don't have good human data on how readily absorbed it is through inhalation, as far as doing causation. analysis, but I just wanted to put those updates out as well. And I
Yeah.
appreciate the work that Phil's doing, and having Los Alamos and the team have something a little closer to home, I think is a big win too for the state. I think there's going to be a lot of interesting things coming out.
I agree. Yes, the lidocaine has been around for a while, and it at one point was very common on the East Coast, and it's been showing up a lot in cocaine samples and things. The quinine also has been fairly common on and off with heroin historically, and the other folks that I checked with say they see it fairly routinely with the counterfeit pills on the West Coast. So I think the numbers with HIDA back in the spring, they were saying 1 in 17. As in more recently, they've revised it to that lower number. And the OMI people did, yeah, they got that grant. And what they said they've been doing is they are doing a urine test, a dip with the xylazine. And if that test becomes positive, then they do an expanded panel on folks.
Okay, any other questions? All right, just in the purpose for keeping us on schedule, we'll go ahead and move on. If anybody, and just to be clear, Phil, you had said that with regard to those recommendations, you'll send something to the Google group and that'll go out to everyone and they can respond directly to you, correct?
Yep.
Okay. Perfect, thank you. All right, so our next item on the agenda is the Integrative Pain Management Subcommittee. Michael, I know you were here. Are you still here? Ah, there you are. All right, I'll hand it on over to you, Michael.
Thank you, Dominic. So this last couple months have been pretty busy. Joanna Katzman and I both went to Japan to do a kinesiotaping seminar, and she spoke about the pain clinic at UNM, and that was really well received. We haven't had a meeting this quarter, but I've been working on the recommendation that we have been over the last couple months. And the further I get into it, the further questions I have. So I've not been prepared to make a recommendation yet. I'll be working on it over the next couple months, and have been in contact with UNM HSC about the workforce report that they put out. But other than that, I don't have much to report.
Okay, all right. Well, thank you, Michael. And hopefully we'll. Oh, Brandon, you had a question. Go ahead, Brandon.
Michael, thank you for all the work you do. Some more positive news, because there's been a lot of positive news actually in this meeting today.
Brandon, something's happening with your microphone.
So no.
My microphone I thought was muted. I thought somebody was giving an applause track or something, but I don't have any comments at this point.
Is it me?
No, it was Brandon Taylor who had a comment. Brandon.
Can you guys hear me or no? Can you hear me or no?
We can now.
Oh, is this better? Am I connected via my Bluetooth somehow?
Yes, that's much better.
I'm so sorry. Okay, anyways, look, sorry about that. What I was trying to say is that I just wanted to, first of all, thank Michael for all of his work and on this committee, and that it's been very busy for everyone. So, and it sounds like those travels were amazing. I look forward to learning more. And also, I wanted to say that there's some exciting news to share. One of them being, in my understanding, that the Medicaid program is finally going to be starting to cover chiropractic services as of January 1st of this coming year. Is that correct, Michael?
Yes, that's correct. And
Which is
we're-
really exciting and a huge milestone. And it takes us another step closer to achieving the goal that was, I believe, clearly established by this body in the unit.
Definitely.
Services that are defined as essential health benefits under the Affordable Care Act for Medicaid participants, as for everyone practically else in the state of New Mexico. Which is really a very, very positive step forward. I have another positive potential piece of news to share, which is that HSD, if anyone's not familiar, has proposed their budget for 2020 for federal year 25, which I believe begins October 1st, 24. That would include 20 visits of acupuncture per year as well, starting October 1st, if the legislature approves the budget. The total cost that they're projecting that
Brandon, sorry, your microphone did the same thing again. So we
hold on,
couldn't hear the
hold on.
cost.
How about this? Is this better now?
Yes, that
No,
is
no.
better.
Keep trying to solve the internet issues, but I messed myself up with the Bluetooth issue. So that was an unforced error. Please forgive me. What I was trying to say is that I think you heard most of that, hopefully, that HSD has proposed a budget of $28 million for the next federal years, starting October 1st, 2024, that would include 20 visits of acupuncture per year, and that
Sorry,
here's the best
Brandon,
part.
your microphone is doing it again.
Give me one sec.
What I would
everyone.
recommend is maybe put bullets into the chat or send it on to the main group, and we can get that taken care of, sent out.
This is super important. Could you just give me one moment? Because it's really important. I'm trying here.
Sure. No, and we understand. We just
Just give me
can't
one moment.
understand you after
There's a
just a few
really
moments.
important point here that I'm really trying to help people to be involved in, because it relates to everything that we've been talking about and working on in this topic for quite a long time now, it feels like. Where is your invite to the meeting? Here it is.
Thank you, everybody, for holding on.
Can you hear me now? Part 5.
Yes, we can, Brandon. Thank you.
Long story short, too late. I know. Oops, I did it again. The point being that that budget of $2 billion per year for all of Medicaid is covered by is actually New Mexico's portion, is my understanding. It could be the entire thing. That is a question mark. The point that I'm trying to make is that New Mexico pays, as most people know, about 20 cents on the dollar into that program every year. So even though it's a $28 million budget being proposed, a tiny fraction of the total Medicaid budget for covering acupuncture for all Medicaid recipients, the state government would only have to be responsible for $7 total million a year. If we look at this in terms of back surgery costs for Medicaid, this is a very small relative number of back surgeries per year that the Medicaid program covers, as just one of many examples. That would cover every single person, all the 900,000, whatever. Sometimes it's 870, sometimes it's 920. I can never keep track. New Mexicans that are enrolled in Medicaid to have that option available to them. So this is a very positive thing. And the reason I'm bringing this up finally is that on December 11th, there is that legislative committee that is the bicameral committee on health, human services, et cetera, that is considering the budget that was proposed by HSD themselves to cover acupuncture. This is their desire after all of the work that has been done and the information that has gone for years, and the recommendation that this council made to the governor on this topic. So I'm encouraging anyone and everyone who is able to write relevant legislators on that committee your thoughts, or Dominic, if there's any way that you can forward the recommendation that was made, or that we can, if we need to make a motion, I don't know, but to make sure that they are duly informed simply in a few paragraphs that this is actually supported by this council. They can ask the governor what they think, but the point being, if that's possible, I think it might be useful, because legislators have a million things on their plates and they don't have a lot of time, and I really don't know what their knowledge base is of this. And I just wanted to say thank you to everyone for listening and being a part of this process on this topic.
Thank you, Brandon. And just so everybody knows, that recommendation is on the council website. So it is available through there. So it is open and public. So. Yeah. And if there's anything else in specific, Brandon, that you would like other people to have, again, you can send that to the Google group, and then everybody on the council and who's on this meeting will get it. Okay, so great announcement, and yes, great news on things moving forward. That is something that has been happening for, or has been in process for quite a long time. So thank you. All right, is there any other business? No other business, so that leaves us to our last item on the agenda, which is our next meeting. So our normal process, it has been to do on the second Friday of the month. And so the next one will be every couple of months. And so the next one would be January 12th, starting at 1:30. Does anybody have any objections on that? All right, well, we will set it at January 12th, starting at 1:30, since all I saw were thumbs ups and head nods. So we'll have that sent out in the calendar here soon, in the next few days or so. And then we'll update the, once we have the recording and some of the other information here in a couple of weeks. All right. And I'll make one last final call. Anybody have any other items, questions, concerns, announcements, anything else? All right. Well, with that, I hope everybody has a wonderful weekend, and I hope that you all have a great holiday next week. So thank you, everybody, and enjoy the rest of today.
Yep, thank you,
Thanks,
Dominic.
everyone.